The last session is on patient and public involvement in research. And Associate Professor Lene Kildal Bragstad from University of Oslo, Norway, will have a presentation on patient and public involvement in research in an international context, examples from the OPTIM-PARK project. So please.
Thank you. And I have a few notes here to not talk too long. Thank you very much for inviting me today to this seminar. I've really enjoyed all the presentations today. And I'm aware that it's late in the day, but I'm hoping the coffee will work. And I'm hoping I won't bore you. Okay, so my name is Lene Kildal Bragstad. I'm an occupational therapist by training, and I have a PhD in health services research from the University of Oslo in Norway. And this is also where I'm currently working as an associate professor. I also have a second job as an associate professor at the Oslo Metropolitan University in the occupational therapy department. So patient participation has been an interest of mine throughout my clinical career as an OT. And as a researcher, I've continued my engagement with perspectives on patient and caregiver participation and on patient and public involvement in research. I am the Norwegian country lead of the OPTIM-PARK project, and my team is responsible for a work package or a sub-project with a specific focus on patient and public involvement. So I'll come back to the OPTIM-PARK project in a little while, as I've been asked to use that as an example of how patient and public involvement can be implemented in an international context. First, I'll outline a little bit about the ambition, or should I say what I've been asked to talk about. So I want to inspire a critical discussion of patient and public involvement in research. You'll notice that I'll use the abbreviation PPI throughout the presentation. I'll touch upon some of the theoretical and practical models of involvement in research and try also to delineate some of the terminology. And I also want to try to at least lead your attention towards some of the potential added value of including PPI in international research, or in national research for that matter. I've also been asked to conclude with a few remarks on perspectives for further discussion, so I'm going to try to do that. So, a globally stated hypothesis in contemporary health research is that patient and public involvement in research positively affects the outcome of research. Researchers, user organizations, research funders, policymakers all operate under this assumption, although the evidence for the benefits of public involvement still remain unclear. And various stakeholders have different perspectives about when and how PPI should be done and why it should be implemented in research. However, it has become a mandatory element of contemporary health services policy and also a requirement stated by research funders and in research policy documents. And the reasons for including PPI as a mandatory element are diverse, depending a little bit on the theoretical underpinning of the research. Arguments may relate to principles of democracy, stating that patients have a right to be involved in research on their condition, in this case, Parkinson's disease. Also, general improvement of the efficiency and value of research by increasing its relevance to patients, extending the range of people represented, also improving dissemination of findings beyond the academic audiences might be important. Another commonly stated rationale and intention is that it will also increase the accountability and transparency of research. And based on this, we can say that PPI can be viewed as a goal in itself, by encouraging participative democracy, public accountability, and transparency. So looking at the world of research today, the thinking around patient and public involvement in the international research community has been influenced by initiatives in 3 highly influential countries. In Canada, the Canadian Institutes of Health Research has developed an initiative they call the Canadian Strategy for Patient-Oriented Research. They've made a patient engagement framework. In the United States, the Patient-Centered Outcomes Research Institute, for short PCORI, was established to ensure that patients and the public have information they can use to make decisions that reflect their desired health outcome. And in the UK, we have an initiative called Involve, which is now part of the National Institute for Health Research. And this has been very influential in the goal to improve the quality and consistency of public involvement in research. And you may notice that the benefit of PPI is taken for granted, and the underlying assumption is that involvement is always positive. So let's look at these countries. An important goal in Canada is for patients, researchers, health care providers, and decision makers to actively collaborate to build a sustainable, accessible, and equitable healthcare system and bring positive changes in health of people living in Canada. In the US, PCORI aims to help people make informed healthcare decisions and to improve healthcare delivery and outcomes by producing and promoting high integrity evidence-based information that comes from research guided by patients, caregivers, and the broader healthcare community. And in the UK, Involve was established in 1996 and is a part of and is also funded by the National Institute for Health Research to support active public involvement in NHS, public health, and social care research. Incidentally, this framework has been highly influential in the Scandinavian countries when researchers have searched for guidance on PPI. Okay, so before I delve any deeper into the discussion of patient and public involvement, I feel that we need to talk a little bit about the definitions and terminology. And according to a recent article by Skovlund and colleagues, patient and public involvement in research refers to the inclusion and activation of patients or public lay people as partners in the various stages of the research process. And also the definition by Involve goes even further, stating that PPI indicates that research is being carried out with or by members of the public rather than to, about, or for them. So in the literature, there's a range of terms used, and there has been a clear development of the terminology and the thinking around participation and involvement over the last 50 plus years, starting with the seminal work of Sherry Arnstein from 1969. And this is still relevant in today's discussions. She described a linear hierarchical ladder of participation, where she emphasizes that it's possible to move up and down the rungs of the ladder. Later, research has focused more on different levels of user involvement that have been defined and measured on a continuum, ranging from a low to a high level of involvement. And within this focus of research, information and consultation are described as the lowest level of involvement. Collaboration is described as cooperation between researchers and users throughout the process, and the highest degree is achieved through user-led research, and that's called, or would be called, partnership. And as you can hear already, there are a lot of different terms that I'm using. And some of these are more or less used interchangeably, and it obscures what we're talking about sometimes. So it might be useful to have at least a common understanding of some of the key terms. This is not an exhaustive list, but a few of the terms that you'll hear me use. So I will distinguish between some of these broad concepts, talking about engagement. That's when information and knowledge about research is provided and disseminated to the public. Participation is a term used when people take part in a research study as an informant or a respondent. And to participate in research is something else than to be involved in research as a patient or public representative. Because when you participate in research, you contribute your own individual experiences or views. And as opposed to involvement is when members of the public actively are involved in research projects and research organizations. So I'll broadly be speaking about involvement from this perspective as something more than just, and again, don't get me wrong, it's also very important, but something more than the individual experiences, so a bit more broadly. So the challenge here is that these words have a more common sense meaning also, and I might use them also in a non-theoretical way, so please bear with me. So let's see, if you venture into the literature on patient and public involvement, you'll probably also encounter a more recent term that's become very popular, and that's actually an emerging field, I would say, co-production. So co-production is a research approach in which researchers, practitioners, and members of the public work together, sharing power and responsibility from the start to the end of the project, including the responsibility for generation of knowledge. And this has traditionally been within the researcher's domain. So the assumption underpinning co-production is that those affected by research are best placed to design and deliver it, and also have the skills and knowledge of equal importance, equal then to the researcher's knowledge. And this is a particularly difficult notion, as the more traditional scientific stance has to some extent also been concerned with creating sufficient analytic distance to the field of study to ensure scientific rigor and trustworthiness and to counteract biases in the research. And there are several examples of instances where researchers with personal experience with the condition which they're doing research on have been discredited due to the lack of an analytic distance. So this means that co-production as a method may challenge traditional scientific beliefs of what is good research. I do, however, believe that we need to reconcile both of these notions and discuss this in each particular project. What are the potential pitfalls and what are the apparent benefits of this approach? Again, the underlying assumption is that co-production is positive and benefit is taken for granted. As co-production is a relatively new approach to PPI, going further than previous theoretical works for involvement, the guidance on how to achieve co-production is written for the public. Also for researchers and health and social care practitioners, but with a particular significance of writing to the public first and foremost. And there is a growing literature documenting how PPI is implemented in different research projects, and there are a number of different models and frameworks that are designed to enhance PPI in different kinds of projects, and as many as 65 different frameworks for supporting, evaluating, and reporting PPI in research was identified in a recent review. And most of these scored high on scientific rigor and was developed using a systematic approach with substantial input from patients and lay people. However, most of the published frameworks were hardly used beyond the groups that developed them. So the plethora of theories, frameworks, and terminology can be challenging to navigate for researchers, PPI representatives, and also for organizations that nominate PPI representatives. So, and it may also be argued that the international research community have maybe unintentionally tried to invent the wheel, in this case, PPI over and over again. Or maybe this abundance of frameworks is a result of everyone thinking their context and project is so unique that we need a specific framework for this kind of project. Looking a bit more into these, in line with my previous arguments on the reasons behind PPI in research, these different frameworks rest on different theoretical beliefs. So in the systematic review by Greenhalgh and colleagues, they created a taxonomy of the different frameworks showing that all of these 65 could be divided into 5 broad categories: the power-focused frameworks, priority-setting frameworks, study-focused frameworks, report-focused frameworks, and the last, partnership-focused frameworks. And the partnership-focused frameworks are designed to assure transparency and public accountability for researcher-lay collaborations. Particular emphasis is placed on demonstrating what measures are in place to support the academic lay partnership and to provide an audit trail or documentation to account for its activities. Focus in these kinds of frameworks are on governance structures, public release of data in the terms of transparency, communication processes, and also training of all involved. Okay. So as the importance of involving patients and the public in healthcare is widely recognized and taken for granted, and there is an apparent willingness to systematize this work as evidenced by the sheer amount of frameworks in play, involving patients and families and the public can have a number of benefits. It has been shown that involving them can improve patient choice, self-care, and shared decision-making, contributing to research partnerships that we want, and changes to service delivery and patient outcomes. And the involvement process has also been seen as an important way in healthcare systems of enhancing the democratic principles and accountability, as I mentioned earlier. However, the benefits that have been identified also have corresponding challenges, and some argue that PPI often appears to be trapped in a vicious cycle. Uncertainty exists about why and how to do involvement well, and how to involve and support a diversity of patients and the public rather than a few selected individuals. And reviews of the literature have shown that users' roles are more often consultative than participatory, raising critical perspectives on PPI implemented as a symbolic effort just to tick a box and satisfy a requirement. So the reality of implementation is complex and yields suboptimal evidence of impact. This fuels the cycle of predictable and also disappointing results and exposes PPI to persistent criticisms of exclusivity and tokenism. Recent literature reviews found a great variation in assessment and reporting of the impact of public involvement in research, and most notably, the impact of public involvement was highly context-specific, which makes it difficult to draw general conclusions. Additionally, the reviews show that the researchers themselves were generally the source of knowledge on the impact of public involvement, revealing a shortage of perspectives derived from the PPI representatives. So giving voice to the public and the patients is one of the main reasons behind PPI. Thus, it will appear quite hypocritical if the researchers are the only ones actually given a voice when it comes to evaluating the benefit of involvement. And this may add further fuel to the criticisms of PPI being included in research as merely tokenism. Okay, in multinational research projects, various regulations, traditions, cultures of patient and public involvement will create different expectations in patients and the public, and differences in the organization of services will create different contexts for implementing PPI. And this notion brings us to the OPTIM-PARK project that I've been asked to use as an example. As I mentioned, I'm the country lead in Norway. We also have the country lead in Denmark here today. And we're working closely together. So my team in Norway is responsible for planning and evaluating PPI in the overall in the project. So going forward, I want to share with you a little bit about how we have organized PPI in OPTIM-PARK. But I do feel like I need to give you a little bit of context. So I'll start by introducing the project very briefly, and then outline a bit of how we have planned the implementation in this international project. So the OPTIM-PARK project has been referenced a few times today, and the full title is Optimization of Community Resources and Systems of Support to Enhance the Process of Living with Parkinson's Disease. And our aim is to create a multi-sectoral intervention. Our project was funded through the JPND, the EU Joint Program for Neurodegenerative Disease Research. It's a 3-year project with a bit of an extension due to COVID. So we're in play for another year in the full project. The project includes a number of partners and organizations in the 4 partner countries, in the UK, Spain, Norway, and Denmark. The project lead is Professor Mari Carmen Portillo at the University of Southampton. And each of the countries have established research teams which have been allocated responsibility for different tasks in the project. And the whole group as a whole are collectively responsible for the project. And of course, the teams are much larger. These are the team leads that were present at our kickoff in 2019. So it seems a long time ago. Okay, so the aim of the OPTIM-PARK project is to establish the feasibility and acceptability of an intervention that will enhance the process of living with Parkinson's disease for patients and family carers. The objective is to build a multi-sectoral care pathway with a specific focus on how to optimize the use of resources and systems of support in the community and in disadvantaged populations of different European countries. You may wonder, how do we define disadvantaged populations in the Scandinavian countries, as this concept is not necessarily clearly connected to people with Parkinson's disease. So to be able to satisfy this part of the project, we have defined the disadvantaged populations based on 4 criteria, and we're not entirely sure that we're spot on yet. But first, we're looking at which populations may be deprived or disadvantaged in relation to educational level. Secondly, in relation to ethnic background or migration status. And third, in relation to social problems, and all of these to a degree that negatively influences their health literacy and their access to healthcare. And the 4th criteria is in relation to deprived or disadvantaged geographic areas, where access to healthcare may be limited or health literacy may be low. So just to give you a very brief overview of the project, work package 1 is an overarching work package where patient and public involvement is the main task, and this is what I'm talking about today. And we also have work package 2, 3, and 4, where we're doing a lot of empirical work, interviews, discussion groups, and we're now designing a, what are we calling it, feasibility study. So my responsibility as the lead of work package 1 has been to ensure that we develop a plan to include PPI in all phases and levels of the project in all countries. So the overall objective and the reason for our focus on PPI is to enable research that produces knowledge that's perceived relevant to users by ensuring user involvement in all levels and phases. And I think one of the things that's quite unique to our project is, or maybe not anymore, but it was a few years ago, that we have a very broad definition of users. And this is, of course, because this is a health services research project, so we're focusing on services. So that means that we need to include all stakeholders, and we've divided these in 3 levels, the micro, meso, and macro level. And the persons with Parkinson's disease and family carers represent the micro level. Healthcare professionals and non-health professionals with key roles in delivering services in the community constitute the meso level, and stakeholders with key roles in policy making constitute the macro level. And in using this distinction, we aim to include representatives from all levels in all countries. And it's also a recognition that in projects with a clear health services focus, we need to include all stakeholders. However, we find that this challenges the traditional notion of user representatives as the end users, in this case, persons with Parkinson's disease and their family carers. So an apparent criticism might be that in establishing PPI groups with this broad representation, how do we ensure equal emphasis to all representatives? Wouldn't the professionals always be in a stronger position in comparison with persons with PD and carers? Well, that's something we want to explore in our evaluation. How is this issue perceived by the different representatives? We have also established a scientific stakeholder advisory group, as it's called. But when I'm talking about PPI going forward from here, I'm talking about the national groups in each of the countries. So establishing a common plan for PPI has been one of the keys in our work with the OPTIM-PARK project. As mentioned earlier, we expect that the 4 different countries have different and various regulations, traditions, and cultures of patient and public involvement. That also means that we do expect some local or national differences in our approach to PPI, but we wanted to establish a joint plan that was agreed upon by all parties. And that has been important in trying to make sure this can be evaluated as a single approach to PPI. So this project is still ongoing. That means that we have not yet evaluated the benefit of this. So I'm referring now to all our good intentions. So this is what we're thinking based on what we know from the theory. So our plan was inspired by the Involve framework from the UK. PPI representatives are seen as active co-producers of the scope, direction, and conduct of research and are involved in the provision and dissemination of information and knowledge. And in the taxonomy of frameworks that Greenhalgh and colleagues made based on their review, the Involve framework is an example of a partnership-focused framework. As mentioned, some of the characteristics of these kinds of frameworks include a focus on measures to support the academic lay partnership and to provide an audit trail documentation of the activities. Furthermore, there's an emphasis on training of all representatives and researchers. So these are a few of the characteristics we have chosen to emphasize in our project. And one key was that the educational program was developed and implemented in each countries. That's our goal. There were 4 key elements in our educational program. So we wanted to explore expectations for participation. We wanted to explore the desire for involvement in different project tasks and the desired level of involvement. We wanted to discuss the values of collaboration within the project. And we also wanted to make a plan for involvement and making a plan for practical agreements, principles for working together. So the background for our approach and selection of key elements can be found in the dialogue model. This model was developed in the Netherlands and is based on participatory and interactive approaches, which enables end users to have a role in decision-making and innovation processes in various societal domains. So the aim of this model is to establish an equal partnership among patients and other stakeholders in the agenda setting process. So the application of this model in our project is not strictly for agenda setting, but we found the model useful as a foundation and for thinking about how to approach establishing PPI in the project. So this dialogue model, it integrates patients' experiential knowledge and voice. It fosters a mutual learning process, which leads to new shared perspectives that is acceptable and recognizable for all involved. That's the plan. And it acknowledges the power differentials and assumes that patients require a safe environment of their own group to develop their own voice. And it does consist of multiple phases, focusing on how cooperation between users and researchers can be obtained. And understanding patient and public involvement as something that's shaped through interaction between PPI representatives and researchers implies viewing involvement as a dialogue. And PPI representatives are stakeholders who are involved in the research process in dialogues with other stakeholders, and they will be regarded as partners. So using this model as a foundation, we tried to operationalize a few of the concepts, key concepts. So we wanted the educational program to identify values and expectations as part of our exploration. Consultation was connected to plenary discussions in all meetings, prioritization on agreeing on how to work together, integration into the specific hands-on plan, and also to have a very specific plan for evaluation. So in the educational program, we start by exploring expectations for participation in OPTIM-PARK. Which expectations do each of the representatives have at the beginning? And more specifically, we ask them to identify or indicate which kind of task they would like to be involved in and at what level of involvement. So the discussions that this inspires will give guidance to how we work with the PPI groups throughout the project. So the intention is to activate those who have indicated a desire to be involved and to target the kinds of tasks and discussions each representative will participate in. And also when we were designing our plan, we tried to ameliorate a few of the shortcomings that were identified in the literature. For instance, we know that even though PPI representatives and researchers may agree on a common definition, researchers found that different values are often assigned to the aspects of involvement, depending on your perspectives and your previous experience. So this emphasizes the importance of addressing the values of PPI and also taking the time to clarify by exemplifying different values and discussing this within the group. And this was part of our educational program and an important discussion in the very first meeting with the representatives. And I want to also emphasize that different values associated with patient involvement should not necessarily be viewed as a negative, but it should be acknowledged. So we need to start talking about how we value things differently. And it is a means to stimulate the debate and to generate new knowledge on patient and public involvement. And also in an effort to increase accountability within the group, we wanted the groups to agree on a plan for future meetings, frequency of meetings, physical versus virtual, and things like that. So this plan was designed for all countries to follow, but of course it has been amended and designed or adjusted in each of the countries. The plan for evaluation, we wanted to evaluate the perceived benefit of impact of PPI in the project, and this is a combination of processual evaluation alongside the project and a more summative evaluation at the end. So our plan is per now to distribute a survey to all PPI representatives in all countries at the end of the project. And we also have funding for a PhD candidate who recently started, who is evaluating the potentially added value of PPI in international projects. And she's using OPTIM-PARK as an example. We don't have any results of that yet because she just started. So I want to give you just a brief idea about who we have included in our PPI groups. And you can see that each country's groups are a bit different in terms of number and representation. And I don't expect you to be able to read this, but I just wanted to illustrate that we do have representatives from all levels in all countries, and that was one of the main goals. Okay. So I want to conclude with some remarks about PPI in international projects. In our project, we have demonstrated that it is possible for an international research team to agree on a framework for PPI, even though there are cultural and contextual differences in each country. And I mean, the existing 65 different frameworks would suggest otherwise. To account for differences, each partner country will have to contextualize the PPI to fit national and local settings and cultures. And these differences are very important and interesting to us to explore to further understand how the same plan can be operationalized differently. And may we also see that the strategy has been more successful or less successful under different circumstances. Also, the process of adaptation and contextualization must be balanced with the need to reach project milestones, gathering data that are comparable, and achieving the shared goal of the multinational project? Is this even possible? That's some thoughts, and I also have some take further messages or questions rather. So what is the significance of PPI in international research for rehabilitation research on Parkinson's disease? And I would like to leave you with a few questions, and I don't have the answer to all of these, so I'm hoping maybe someone can discuss this further. So the first thing is, should we accept the taken for granted notion as PPI as a positive, or do we actually need to do some more serious research on this, this perspective? Would it be more interesting to develop a critical view on the value of PPI in rehabilitation research on Parkinson's disease? Who do we define value for, in which context and under which circumstances? And I'd also like to draw up another question. How can we avoid the perception or the interpretation of PPI as a symbolic act? How can we actually increase the credibility of our PPI initiatives? Is a dedicated work package in a project enough, like in the OPTIM-PARK project? Can we do more? Who should be in charge? Should we actually follow the notions of co-production and implement co-production as a standard? These are some of the questions that I've been thinking about and that I think might be interesting to discuss. I have some references, and these you can ask me for these later if you want. Okay, thank you.
Interesting. Any of you working with PPI in your research? Or questions for Line? Well, I'd like to ask you something, because we work with patient involvement in all our research projects, and actually we use like an initial meeting with the PPI patient who are involved, as we call them, patient research partners. What do they want to become involved in? And we also try to evaluate along the way. But I think the most useful part of that is actually on a like a vast scale. They indicate how much they think they contribute, and the responsible research also marks. So it becomes a very nice discussion on. Sometimes they think, well, it doesn't really mean anything, and I'm just here. And actually, the researcher may think, well, it's very valuable with the input you've come with. So how do you find your evaluations here? Do you learn from them to become better somehow?
Yeah, so we haven't evaluated the whole thing yet, but we do have some evaluations of some meetings. And I think one of the things that stick out is that because we're involving people or stakeholders from different levels, so we have the professionals together with the persons with PD and also together with carers. I think what we see is that those who have a very keen sense of or an interest in research, they want to participate in a lot of the strictly research activities. And the users are a bit more timid, I would say, in saying what they would like to be involved in. So the traditional users, the persons with PD. But it also depends on what kinds of experiences they have, is my impression from our first evaluations. Yeah.
Questions? So how to select patients for research? Another question.
That's a very good question. Yeah, we have, fortunately, we do have a very good working collaboration with the Parkinsons Association that has helped us a lot finding people that are very interested in these kinds of projects. So we've had a lot of use of that relationship in Norway, at least. But yeah, it's difficult.
Yeah. Yep.
Well, Thank you, Line, for a nice presentation. I was wondering, you've been here all day, and today we've been talking about cognitive impairment and interventions and strategies for that. Have you had any reflections during the day about how PPI may benefit research focusing on developing interventions targeted at cognitive impairments in Parkinson's disease?
That's a big question.
Yeah, you can handle it.
Yeah. I do believe that that there's a lot of potential in using PPI groups very actively in developing interventions, and I do also think that interventions for people with cognitive decline is very important. And I do think that we need to, as the previous speaker said, we need to listen to those who actually experience this. And I would very much like to have someone who are in the position that they would need some kind of cognitive intervention to also be part of our PPI team. But yeah, I don't know. There's a lot more to be said on this. Yeah. Yeah.
Any more questions? Are you just getting tired? Or...
I bored them to death.
No, the time of day. Yeah.
I think, oh, sorry. Thank you for a very nice presentation. And I love the way that you are actually also giving us some of the, both the benefits, but also some of the doubts as to this, because it's really been like floating around for a long time that we need to involve. So thanks a lot for giving us a lot of things to think about. But when I hear your presentation, I also think that it sounds as if it's a very strict framework that you're operating with. So it's kind of you have decided that you really want to go all in on PPI. And I think it looks as if it's a lot of work and it's a lot of resources going into that. Is it worth it?
Very
Sorry.
good question. Yeah, I don't think I'm in a position to answer that yet until we've evaluated. But and I do know, and I agree with you, the plan looks very strict. And it's not as strict as it looks on paper. So it's a bit more flexible in each of the countries, and each of the countries are doing it a little bit, also depending on what kind of resources they do have within their team. But yeah, we're very curious about that question and the answer to that. So yeah, very good question. Don't know yet.
So I saw that you were working with the development of interventions and complex intervention, that framework. Yeah. And then it's natural to have user involvement. But do you have any thoughts about, are there any research methods or research areas, basic research or anything where you think, well, maybe it doesn't make sense here? What do you think?
Yeah, that's a good question. I think we're all just kind of caught in the notion that it's a requirement and that we were not even allowed to think those thoughts. Where would it not be? But I have participated in a panel for the UK MRC, incidentally, and on more of the basic sciences research. And there it's difficult to see how PPI would be implemented in rat studies, for instance, or like, but I think there will be representatives that have some kind of valuable input in.
Maybe in the interpretation of the results, I don't know.
Of course.
Yeah, okay. Well, thank you very much. You should give your hand.